this, we're taking 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 with a pinch of salt.
Dear colleagues, welcome in today's A Pinch of Salt, a podcast series offered by the ERA. I am George Kosmadakis, and the subject today is the treatment of arterial hypertension in 2025. In latest years, there were new guidelines on hypertension, and there were a lot of discussions concerning these guidelines. It seems that office-based optimally measured blood pressure measurement might be important. We have several grades of arterial hypertension depending on the concomitant comorbidities, and the treatment targets are becoming stricter. Today's guest is an eminent specialist on the field. Professor Pantelis Sarafidis from Aristotle University of Thessaloniki in Greece has participated in the various committees that issued these international guidelines and is a member of the ERA Council, one of the biggest specialists in the subject. Professor, welcome to the Pinch of Salt.
Well, thank you for having me. That's a great opportunity, and I hope we will have a fruitful discussion and clarify a few things.
Hopefully. I'm sure that it will be. Well, I will start with a naive question, as always. If I want to be up to date today, which are the guidelines I should read about arterial hypertension?
Okay, so that's a fair question. Well, my personal opinion, and it is also the opinion of several experts belonging in the European Renal Association, and this is because the European Renal Association has officially endorsed these guidelines, is that we should be reading the European Society of Hypertension guidelines that were published in June 2023. And there are several reasons for that. First is that there has been a tradition in this European Society of Hypertension guideline document. It is out more or less every 5 years, and on several occasions, it was one of the most cited papers around the world. It follows a specific pattern of evidence-based review and different chapters. It also covers in I would say, a huge extent, lots and lots of different areas, different subgroups, including what we are interested in, patients with chronic kidney disease. And in the latest version of the guidelines, I think I remember there were 8 prominent European nephrologists and 1 pediatric nephrologist among the author lists, and they have done an extensive work to clarify things. In addition to that, a group of people from the European Renal Association and the European Society of Hypertension, because there is a lot of collaboration over the past few years, especially with the EURICAM working group of ERA, have written a synopsis of these guidelines on things that are of interest to nephrologists. So if you have a lot of time, you can go and see the whole document of the European Society of Hypertension. If you don't have a lot of time, there is a very, very good document published in NDT a few months ago that is absolutely free. It is, I think, let's say, a 5 or 10-page document where all the important issues on hypertension in CKD patients are included. So you can be updated with much less effort.
Well, and that could be probably the end of the podcast, but
all right, okay.
we'll have some time to discuss about the content of these guidelines. So ERA is clearly endorsing European Society of Hypertension guidelines. We have all the information important for the nephrologist in this article. And what is new about these guidelines? What has changed?
Okay, so if I just may add something, because I don't want to sound in favor of one against another guideline. The European Society of Cardiology has issued also guidelines a couple of months ago in end of August 2024. This is a nice document. There are some differences in a few, I would say, in a few areas with the guidelines of the European Society of Hypertension. These differences are not major, and in most of the part, the actual the major recommendations are on the same page. The European Society of Cardiology guidelines have not devoted a special part in for patients with chronic kidney disease, and for that reason, there is another major guideline that is prepared and is probably going to be published in 2 years from now. And this is a collaboration of the European Society of Cardiology and European Renal Association, and there are experts of both sides coming in, and the guideline will be on cardiovascular disease, including hypertension, in patients with chronic kidney disease. So there will be a lot of information in that guideline too. So I think that the European Renal Association is working very well in a balanced way to accumulate evidence and offer recommendations to our fellow nephrologists. So I'm talking too much. I'm sorry, but probably I should have said that. So hit me now. I'm ready for the next question.
So until we have these new guidelines, we should be based mostly in the 2023 European Society of Hypertension.
And it's a lot of details on what to do with. So you were asking what is new. Am I correct?
Yes.
Okay. So I would say that a lot of things are not new, but there are also important things that are new. If I may start from the things that are more or less the same. So the actual classification of hypertension in the actual classification of systolic and diastolic blood pressure, what is optimal, what is normal, and what is high normal, and what is hypertension grade 1, 2, and 3 is the same. So for the overall population, including people with chronic kidney disease, we consider a patient to be hypertensive if their systolic blood pressure is above 140 and the diastolic blood pressure is above 90 millimeters of mercury. And this is when we label the patient as hypertensive. And this is there for a number of years. We don't know if it will be changed in the future. So that's number one. In addition, the cardiovascular risk stratification, according to grade and stage of hypertension, remains mostly the same. I don't know if you have seen the actual figure, the actual chart is very much similar to what we have as nephrologists, the famous KDIGO charts with different colors identifying moderate, high, and very high risk. And in the European Society of Hypertension chart, the presence of CKD stage 3 or above identifies as a risk factor, as a major risk factor. And then if CKD is stage 4 or above, then you move to another part of the table, those with very high risk. So CKD is a central part of the cardiovascular risk stratification in the hypertension guidelines. So if I can move to what has changed, the European Society of Hypertension guidelines has a couple of important changes, if I may. Perhaps the most important one is relevant to the treatment target. So until the previous guidelines, I would say that the European Society of Hypertension was more on the conservative side regarding treatment target overall. and especially the treatment target in chronic kidney disease. So until 5 or 6 years ago, the treatment target in patients with chronic kidney disease was below 140. So this time, in the recent guidelines, there is a big analysis of all the actual studies in the field involving the older studies, the ASK and MTRD studies, and also the ACCORD and SPRINT trials. And what is now recommended with a level of evidence that is not 1A, of course, it is to move to blood pressure, systolic blood pressure levels below 130 in the majority of patients with chronic kidney disease. So that means in all the patients that have high or very high albuminuria, especially the young patients, the patients with high cardiovascular risk, and then you can have a personalized approach to go to the standard target, I would say, below 140 for all patients. And then, of course, there are different subgroups, elderly patients that can be, the very elderly can be dealt with a more careful approach. So the major change is that the blood pressure target should be below 130. In addition, the recommendation in the European Society of Hypertension is that we should not aim for a target below 120. So if your patient is proteinuric, you prescribe them an ACE or an ARB, and their blood pressure is 118, and it is well tolerated, everything is fine. But if their blood pressure is 125, this is also fine. We should not aim by adding additional drugs to reduce it below 120. So that's something that is new. And then there are different things that are new in our approach to treatment, but then we can discuss that in more detail if we have time.
So you consider that proteinuric patients should have lower targets?
I would say that in the majority of patients with chronic kidney disease, and those include patients with proteinuria, what we used to call them, now we call them with albuminuria, and also patients that are normoalbuminuric but have high cardiovascular risk, and young patients that can tolerate, we should go to systolic blood pressure below 130, but we should not target for a blood pressure below 120/70. And that's a very clear recommendation.
Perfect. What about the office-based measurements and ambulatory measurements?
That's a very good question. Okay, thank you for bringing that up. So this is a major discussion that has been going on forever. And what happens is this. We know that we have to aim for what we call standardized office blood pressure measurements. So there is, again, very clear recommendations in the guidelines with very clear figures on how to take a standardized blood pressure measurement. And this follows what we know for decades from our textbooks. So the problem is that even we have the office blood pressure measurements taken in the best possible way, the standardized way, there is still a lot of patients that will have white coat hypertension. So in reality, their blood pressure is lower from what we measured in the office, or masked hypertension. Their blood pressure is actually higher from what we measured in the office. And there have been a lot of studies more or less telling us that 1/3 of patients with CKD of different stages have either white coat or masked hypertension, including patients on hemodialysis. And in transplant recipients, the percentage of masked hypertension is even higher. So these people have particularly high masked hypertension because most of them have nocturnal hypertension. The thing is that all the recommendations that we can make are made on the basis of office blood pressure readings, because all the studies on which we base the recommendations, especially the studies on blood pressure target, have used only office blood pressure readings. So despite the fact that we know that there are better metrics to see what is really going on with blood pressure, the actual recommendations are still based on office blood pressure readings. So having said that, there is again a very good discussion on when to use home blood pressure and when to use ambulatory blood pressure. And especially for ambulatory blood pressure, this is to exclude white coat and masked hypertension, and also to capture what is going on through the night. And because our patients with chronic kidney disease have a lot of issues with nighttime blood pressure, and they have, I would say, improper dipping status, the chronic kidney disease patient subgroup is one of the subgroups where ABPM is recommended. So we can use ABPM as much as we can, and then we can use ABPM to judge where the real blood pressure of the patient is. But for the overall population and for patients with kidney disease, we still can't use ambulatory blood pressure to make the main recommendations. So this is where we stand now.
So we do ambulatory wherever we can or wherever we suspect, and but we cannot do it to everybody.
Well, we can do it to everybody if we have the facilities. So, for example, in my center, we do it in almost everybody. So what happens if you have an organized, let's say, hypertension clinic or hypertension renal patient clinics? In most of the time, we do rely in home blood pressure measurements, and this is not a difficult thing. In most of the cases, this is a very easy thing to do. Patients are happy. They measure their blood pressures at home anyway. What they can do, they can actually be properly trained on how to take proper home blood pressure measurements. And this is another important factor. When we actually educate the patients, we give them another thing to look for, because hypertension control is overall very, very important. And then if home blood pressure is done properly, then you can have once every 2 to 3 years an ABPM to see what is going on through the night, which is also very, very important. So the reality is that, the European Renal Association, especially the EURICAM working group, has worked a lot in those issues for the last at least 10 years. The reality is that our patients do benefit from out-of-office measurements. And I would say, that's my personal opinion, that patients with chronic kidney disease are the ones that are benefit the most if you use these things. But we cannot have 1A recommendations. So we know that they are better, but we cannot make the recommendations based on them because we don't have
Data.
big trials with them.
Yeah. So perfect. I will pass on now to the treatment.
Okay.
Are there algorithms of hypertension treatment have changed during the last years?
Well, that's a very good question again. So we have a couple of changes that are there. So let me know what we have. Let me tell you what we have. There are changes on two major areas. the European Society of Hypertension has traditionally clear algorithms on how to treat blood pressure. So the main step is to use a therapy based on a RAS blocker, an ACE or an ERB. And the recommendation already from 5 years ago was to give combination therapy, so a RAS blocker, either with a CCB or a diuretic. So for patients that do not respond, you should use all of these three classes
Categories.
together. And then, if the patients still do not respond, then you need to see if the patient has resistant hypertension. So at this step, you need to evaluate most of the patients with ABPM, because this is the crucial point. You need to do two things: to check if the patient is actually taking their blood pressure, and then to check them with ABPM. And then you should probably thoroughly search for secondary causes of hypertension. And in our case, we should be checking for atherosclerotic renovascular disease in a lot of patients. And then there is the new thing coming on. In the previous guidelines, as a fourth step, the recommendation was spironolactone for everybody. But in these guidelines, there is a clear distinction. So spironolactone is now recommended for patients that have GFRs above 30. So I was voting for 45, but again, 30 is an important step. So people that need another drug and have GFR above 30, they can go for spironolactone. People that have GFR below 30 and they are already treated with a proper dose of a loop diuretic, then the recommendation is again new. It is 1B. You can use chlorothalidone, and this is based on the New England Journal of Medicine paper by Rajiv Agrawal on chlorothalidone. And after that, you can use other drugs that are very helpful, but then we move to the hands of hypertension specialists. So you can use a beta blocker, let's say bisoprolol, it was tested in the pathway study, or an alpha blocker, we nephrologists use them very well, or a central acting agents. So now you have 7 agents, and the extreme majority of the patients, even in our hands, would be treated and controlled properly. So that's the algorithm of how to treat blood pressure increase in these patients, how to treat hypertension. Another addition in the latest guidelines is that the recommendation now includes also the drugs that are good for your kidneys, the nephroprotective drugs. So ACEs and ARBs are already there because they're included as first step for the hypertension treatment anyway, but there is a clear recommendation, 1A, for HLT2 inhibitors in patients with diabetic or non-diabetic kidney disease, with the GFR cutoff limit, if I remember well, at 20 mL per minute.
20, yes.
And there is a recommendation for the non-steroidal MRA finerenone in patients with CKD and type 2 diabetes, with eGFR levels at 25 and potassium levels below 5. Of course, if the patient is not taking spironolactone, if you know what I mean. So there is these two additions separately, clearly, on factors that you have to use to reduce the risk of progression of kidney disease and cardiovascular disease in patients with CKD. So there are a lot of new things in CKD.
Yes,
and if I may, I'm talking too much, I'm sorry.
No.
For the first time in the European Society of Hypertension guidelines, there is a clear set of recommendations and a discussion for hypertension in kidney transplant recipients. And there the target is clear, below 130 over 80. There is not a clear recommendation because the data are not there for an ACE or an ARB first. So we can use a CCB or an ACE and an ARB. If there is albuminuria present, you should use a RAS blocker. Otherwise, CCBs work equally well in preserving renal function and kidney transplants, and a lot of different things that somebody can find there. It's not a big chapter, but it's there, a small section, and it's clear. So I think I remember everything.
Well, it was a wonderful photo
What is new?
of the guidelines, and it is very congested and very well performed. So I think we don't have a lot of time to ask any other questions, so we'll get now to the personal one that we're asking always our guests. And it is if you were in a desert island, which book, luxury item, and two songs would you take with you?
Okay. So for a book, I think I will take The Name of the Rose by Umberto Eco,
Eco?
because that's my favorite book since I was in my teens. For
A
two
masterpiece.
songs, I would go probably with Sultans of Swing by Dire Straits,
Great.
and I don't know, Sunday Bloody Sunday by U2. And for a luxury item, I don't know if I can remember something. Probably I will take a good pen with me just to, remind me that there's life out there also.
A pen.
Yes.
Perfect. Just a word about your town, Pantelis.
Okay. So my town, I'm working and living in Thessaloniki, Greece, which is the second largest city in Greece. It's a very beautiful town. It's about 1 million people. We recently had our metro coming out after years of waiting, because the main line hit exactly the main street of the ancient Thessaloniki and Roman Thessaloniki and Byzantine Thessaloniki. So there were lots and lots and lots of delays, because the artifacts have to be moved out and then put it back in again. But the actual result is really phenomenal. So it has been worth the waiting, because we didn't know that all those things were just below our legs. So
Well,
I'm hoping that we will have a big meeting from the European Association at some point, and then people will see and they will probably love the city.
it will be a pleasure. I will have to add that the restaurants in Thessaloniki are something
The food is there and the nightlife is there also, but we are seniors now, we don't go out that much.
Well, so dear colleagues, the workup of blood pressure in our patients conserves its cruciality in the standards of care. The updated guidelines stress the importance of an efficient treatment of high blood pressure after its meticulous detection. More podcasts are available in all digital platforms. Thank you for being with us.
Thank you, George. Thank you, everybody. Bye-bye.